Hi, everyone. I'm Gulnar Feerasta, Director of Programs at the LGBT Community Center of Greater Cleveland. Thank you so much for inviting me to be here with you today. I will be focusing on the approaches that were utilized to gather input and feedback from the community to further define and hone in on specific strategies that would be incorporated into this plan. So just a brief overview of our process. The advisory committee met virtually over the between April and December of 2020 as we developed the plan and we looked at strategies. And part of this committee, we had a subcommittee which was formed to get feedback from members of different stakeholder groups to ensure that there was sort of a public vetting process. And so we had several different methods of getting this input and feedback. We had 2 virtual forums. We had surveys with questions related to each of the strategies that we defined under the 4 pillars. And then we also provided the slides with each of the strategies on the website with the feedback form so folks could give feedback directly related to each of those strategies as they went through it. This is where the LGBT Center sort of plugged in most actively, which was in recruitment, making sure that people knew that this was happening, making sure that we were sharing any promotional material, flyers within our formal and informal networks and on social media to encourage participation. We also developed a 1-word video about the ending the HIV epidemic that we pushed out as part of this promotional campaign. We hosted and facilitated some of the focus groups that were held specifically targeting the LGBTQ plus community, and these were hosted by the center and then co-facilitated by our staff in partnership with other members on the task force. We did a lot of outreach. We disseminated and administered surveys in the local communities at places where we know that LGBTQ folks are likely to congregate and gather and to be in community. We also utilized our peer-to-peer networks that we have and other spaces like bars, LGBTQ-friendly community spaces. All of those were sort of avenues that we tried to do really active outreach. It was a little bit harder because of the pandemic, but we made our best efforts. And so these efforts culminated in over 100 attendees participating in the virtual forums and focus groups where we also did breakout sessions. And then we had almost 40 people that responded to the survey that was being disseminated out in the community. And then taking all the information and input that was gathered from the community, we incorporated their suggestions, their ideas, tweaked things based on their suggestions. And these were all part of the final strategies that were submitted in the comprehensive plan. We also, once we redefined our strategies and we did send it back out to the community to get feedback to make sure that the plan was reflecting what they had communicated to us. So it was a 2-step sort of public vetting process. So that being said, this was sort of the lens that we were asking stakeholders to take, help us understand the current situation, help us understand what would help improve the situation. What are the real barriers that folks are facing in terms of not just getting into care or getting connected to care, but just also around prevention. And then getting feedback around, well, what is the likelihood of success, do they think, of these strategies being adopted and implemented? And so these were sort of the 3 focused lenses, I guess, that we asked stakeholders to take when we were interacting with them and getting their feedback. a little bit about the stakeholders that responded. So, the folks responded included Black and Brown folks, people living with HIV, transgender, and gender diverse individuals, as well as professionals and providers that are working directly with people living with HIV or AIDS, and also doing prevention work out there in the community. It was interesting for me when I looked at the spread in the age groups that we were able to reach and engage. That yes, we have folks from the 18 to 24-year-old group, but the participants, for the most part, at the beginning, tended to be those that were 65 and older and were living with HIV, which was interesting to me because the current profile it identifies younger individuals at most high at risk, or where the rate of transmission, new infections, is happening. And so that also helped inform our recruiting strategy when we got our first round of data in, and then doing more targeted recruiting. We hosted a separate focus group just for trans, gender nonconforming, gender diverse individuals here at the center, because that was a voice that was missing. And so we needed to do more hands-on targeted outreach through those informal networks. So as the data was coming in, we were also tweaking and modifying our strategies for engaging the community. We had a pretty even spread between those that identified as white or Caucasian and those that identified as Black or African American. And we had getting input from the Hispanic or Latino community was at 4%. It was pretty low, and this was sort of the demographic that even for us was hardest to reach and engage with. But I think overall, in terms of population, it was pretty on par in terms of reflecting the larger population demographics. Some additional demographics. I mean, you see, folks that shared how they identify in terms of orientation. And then we had various subgroups that were of interest, and particularly we wanted to focus on making sure that we're incorporating input and feedback from those who have experienced incarceration, those that are using or injecting substances, sex workers. Around 40% of the people that we engaged with were living with HIV. 2/3 of them said they'd been tested for HIV in the recent past. And it was also interesting that the majority of our respondents identified as female, and only 1/3 identified as male. It's just, again, shares a little bit about our sources of input. We also did, we did several focus groups, the 2 virtual events, and a survey with bar owners and staff, and then individual interviews. We did several of those. This was interesting from the bar survey, that the piece that's highlighted, that around 45% of bar owners and staff knew where to direct people if they were interested in getting tested. I think that that's really important, and maybe that's a really great area to focus education on in terms of prevention and providing supports and resources. We've done at the center, we continue to do a lot of outreach at the queer bars, but maybe, wanting to expand that out around, promotional materials related to HIV and testing, but also safe sex supplies like condoms, dental dams, lube, those kinds of things. And I was really happy to know that none of the bars indicated that they had no interest in sort of providing education and prevention materials on site. So that to me was actually quite a positive. Just a little bit more in terms of, specific things that we learned and what we got back. So, are folks concerned about contracting HIV? 50% said yes, 40% said no. And so that tells me, for me, I take that as yes, people are interested in the information and want to know more about prevention and keeping themselves safe and having safe sex. Also, that sex isn't the only way that HIV is transmitted. So, doing more around marketing campaigns with PrEP, with reducing stigma, continuing to do our outreach at the bars and also at Pride. Um, this was really interesting where folks, based on your experience, do you find patrons of your bar, people that are coming into your bar, are they open about their HIV status? 40% were said, well, I don't know, I'm not sure, but 35% said yes. I think that that's really great. I think that, if you looked at this maybe 10 years ago, maybe even 5 years ago, this number would have been far lower. Whoops, I'm overly enthusiastic. um, but I think that that this shows that our work to reduce stigma is working, but we need to continue to do that work around reducing stigma and ostracization. Um, and, again, here, only 10% said that they had observed that if folks disclosed their HIV status, that they were treated differently. So combined, this tells me that, we've made significant steps in moving forward around reducing stigma. We need to continue to do that work, but it's not as bad as it was. So I think that we can take hope and optimism from that. Um, there was definitely interest in wanting to keep safe sex supplies on site. A lot of the patrons are open minded and wanting to learn. And the biggest reason that folks were scared or reluctant to disclose their HIV status was fear of rejection from people or potential partner. So a lot of that makes complete sense and falls in line with some of the things that we've talked about. And so continuing to do that work and looking more at these spaces of social gathering as a avenue for reaching people, which goes directly into the overarching strategies. So based on everything that we learned in the focus groups, we identified 8 overarching strategies that would guide our work. And so for example, when we talk about LGBTQ inclusivity and care, right? Yes, I'm biased, I'm from the center, but point being that when you have a population that has historically faced so much trauma and stigma just for the way that they identify, getting through the front door or getting past that initial phone call to schedule a appointment for preventative care is already so difficult, and there's so many barriers to that HIV or any other like health concerns sort of much lower on the priority list because you're just trying to get in through the door and get access. So really focusing on equitable, inclusive care and equitable access to care. When we had conversations with some younger folks, and we hear this quite a bit here at the center too from our youth that are in our youth programming around access to PrEP. They say, yeah, PrEP is great and everything, but I don't want to use my parents' insurance because of all the other sort of barriers that brings with it, including if you have families that are not affirming. So how do you pay for that cost, right? There is a PAPI program, but that's only from my understanding, it's only if you don't have insurance. And in this case, they do have insurance, so they have to use their parents' insurance first. That's a barrier. So we need to find ways to make, given that the epi profile is identifies younger individuals and youth as at most high at risk, and also where most of the new infections are occurring. We have to do more to make PrEP available and accessible. Folks talked about the role of systemic racism, that sort of plays into all of these other areas that we see over here, including modernization of HIV laws, workforce development. So really taking a more intersectional lens, because if you are queer and you are a person of color, you are far more likely to either have unstable housing or be homeless than a white peer. And then, that sort of trickles down into opportunities for employment. It's really hard to get and keep employment if you are housing unstable. It's really hard to get and keep employment and have stability in your life if you are not just housing unstable, but also then food insecure, right? And so, in terms of providers and especially the healthcare system, really looking at it from the lens of social determinants of health. Sometimes I hear from folks in the healthcare system or medical professionals, well, our focus is just on the physical health, and there's only so much we can do. And I say my counter to that is, you have a lot of privilege and you have a lot of power in the systems that you work. Maybe one person alone may not, but if you collectively advocate, then you can make changes that impact the larger landscape of social determinants of health that are directly impacting folks where they are. And so, with that, I will end it here, and definitely open to questions when we get to that part. Thank you so much for having me.